Thank you, Dr. Bala, for inviting me to this galaxy of speakers, the International Ophthalmology Conclave. Am I audible?
Yeah, you are. Please
Yeah.
carry on.
So my talk is on phacotrabeculectomy. So we all know that cataract and glaucoma is one of the leading cause of blindness worldwide. It is the most common ocular condition associated with the aging process, and the prevalence is increasing due to increase in the lifespan. So there is also an increased risk of nuclear sclerotic cataract with elevated IOP and also with glaucoma medications. So why do we consider or think of phacotrab? Phacotrab basically is a combined surgery wherein cataract and glaucoma, both these issues are addressed in a single surgery. So it provides early visual rehabilitation of the patient with cataract and glaucoma. It reduces the risk of severe post-operative pressure elevation, may provide long-term reduction of IOP and decrease the need of glaucoma medications. So what are the indications for doing a phacotrab? So there should be a cataract in a glaucoma patient who is having failure to achieve target pressures by medications. There are issues related to compliance and adherence to medical therapy. There is an adequate IOP control, but significant drug-induced side effects. There is a borderline controlled IOP with the disease progression on near maximum medical therapy, and there is an advanced glaucoma damage. So basically, these are the indications of phacotrap. When we look at the preoperative considerations, there should be a significant visual loss which has to be understood and addressed to the patient that is it due to cataract or glaucoma, because cataract visual loss can be regained, but the vision loss which is there due to glaucoma can't be regained back. So this has to be counseled to the patient before the surgery. So we have to try to understand what is the reason for the significant visual loss. On scan of examination, we have to look for pseudo exfoliation. If the entry chamber is shallow, we have to be prepared accordingly and look for the myotic people, because most of the patients who are on phyllocarbon therapy, you will have a small rigid pupil, and we have to be prepared to handle this situation. Fundus examination is done to understand the amount of glaucoma is optic neuropathy, and also if there is any other macular or retinal pathology which is associated with it. So special considerations in combined surgery, that is phacotrab, is especially when we encounter a myotic people, there is an irreversible meiosis. So we have to pre-plan before the surgery. How are we going to manage this myotic people? So there are these pupil expansion devices like the rings, hooks, and expanders, and we have to be prepared with one of these devices, and we should be well versed of implanting this. Coming to the viscoelastic substance, sodium hyaluronic, it maintains the flat anterior tonsil and deepens the AC. It should be thoroughly washed at the end to avoid post-operative IOP spikes. And HPMC, it causes less post-operative IOP elevation compared to the high-density viscoelastic substance. So these are the choice of viscoelastic which have been mentioned. Coming to the rexis, it is always adequate. It's 5 to 6 millimeter rexis. Coming to IOL selection, you can inject PMMA, acrylic or silicone IOL. In case of no capsular support, there's a big move for AC IOL. AC IOL has to be avoided when you're doing a phacotrab. You can use an iris claw lens. And coming to the techniques of combined cataract surgery plus trabeculectomy, we have the single site technique and the twin site technique. So phacotrab can be done as a single site or a twin site, but whereas SICS trab, if you're planning, it has to be done only as a single site technique. So I'm going to show two videos of a single site and a twin site phacotrab. So this was a case of trabeculectomy with phacoemulsification in a case of small pupil, and this small pupil was addressed using manual ray pupil expansion device. So always after taking a superior rectus suture, you mark your you mark the conjunctiva and usually take 3.5 to 4 millimeters. And once the conjunctiva is marked with the help of a conjunctival scissor, you do a subconjunctival dissection. You dissect the conjunctiva as much posteriorly and behind as possible so as to have a diffuse blood. So after the conjunctival flap is made, you cauterize all the bleeders. You have to identify the bleeders and cauterize that. You don't do a vague diffuse cautery. Always try to identify the bleeders and cauterize only the bleeders. If you are planning to use antimetabolite, I always advocate that you use a metal sponge. You soak it into micromycin, and the dose and the duration depends on the choice what we are versed with. And once you use the micromycin, wash it thoroughly. You have to make sure that everything is washed thoroughly, and never use cotton swabs to use antimetabolite, because you don't want any cotton fiber to be left over, because that can cause scleral necrosis. Next step is to mark the scleral flap again 3.5 millimeter at the limbus and about 3 millimeter at the apical end. I am always using a triangular flap, so you can use a triangular or a rectangular flap. With help of a 15 number plate, you raise the apex of the triangular flap, and once this flap is created, now for this training strategy, you shift temporarily. So you can see now I shifted temporarily. It is a case of complicated cataracts post-uveitic. There is a small pupil. I've done a cyanocolysis after injecting dye under the air bubble and after injecting sodium hyaluronic. So after doing cyanocolysis, also the pupil was not dilated much. So after making the main corneal incision, I plan to use the malign ring. Now the beauty of this pupil expansion device is the use of malign ring DX or the OAS iris expander is that it can be injected through the same opening the same main incision what you have done so that you can inject this device and then fix it against the pupillary border. So there are different techniques for the different devices. So ultimately the main aim of all these devices is that you should have a 5.5 to 6 millimeter centered well dilated pupil. So with this device you can see that the pupil is now nicely dilated and maintained. These devices lie at the pupillary plane, so that is a great advantage. You don't have any peripheral shallowing of the anterior or anything. And now you proceed with the normal phaco technique. Whichever technique you are well versed to or used to, you proceed with that technique. After doing the rexes, I'm well versed with the stop and chop technique. That is the most comfortable technique I'm used to. So I do the stop and chop technique. And what I follow this dictum is whenever you're doing the phaco trap, I always do a slow motion phaco emulsification because I don't want much of fluid turbulence into the anterior chamber because I don't want any pigment dispersion because this pigment can clog up the trabecular meshwork also and plus there is a lot of pigment dispersion which we don't want. So you lower the phaco settings and do a slow motion phaco emulsification. So once the cataract is emulsified and the cortex is washed, the IOL is injected and now the IOL is injected into the capsular bag. And whenever you are doing a phaco, I always make sure that IOL is in the bag. And as I dictum, I always keep the haptic at 3 and 9 o'clock position. And this pupillary expansion device is now disengaged from the pupillary border and is reloaded into the injector and then taken out. Now coming back to the superior side, we have created the flap. Now you just have to make the internal ostium, that is do a trabeculectomy. You can do that with the Kelly's punch or 11 number blade or an MPR. So this is 2 by 1 internal ostium. I've done with the help of 11 number blade. And once this internal ostium is made, then the phacotrabeculectomy is done. Whenever I'm doing a phaco trap, earlier I used to take one intermediate suture and two releasable suture. But now I'm taking only one releasable suture. So as you go on doing your surgeries, you refine your technique and then you see what works well in your hand. And based on that, you go ahead with that. This is one of the earlier videos. So I've taken one intermittent apical suture of 10-0 electron. And now I'm putting a releasable suture. The technique of releasable suture again is very easy. You pass the suture parallel to the limbus clear cornea. Then from the color clear cornea into the spiral bed, perpendicular to the limbus, the next bite is passed, and then from the spiral flap into the interstitial. And you take four throws, the shoelace pattern throws, and tighten it. Now, coming to the congenital closure, it is very important that you do a proper congenital closure technique. You anchor the congenital suture at the episcleral tissue or at the limbus so that the blood doesn't get retracted posteriorly because of the late closure mechanism. There are always chances that the blood can get retracted posteriorly. So the two anchoring suture at the limbus is very important, and you should have a nice watertight closure of the congenital flap so that there is a posterior diffuse flap. So this was the twin side technique which I had shown. And coming to the single side technique, uh, everything is same in this. The only difference is that whatever triangular flap you have created superiorly, you after creating the flap, you enter into the anterior chamber. Okay, so this is the same thing what I'm showing the video. The initial steps are the same. So again, marking bleeder. This is very important. Coming to the mitomycin, as I told earlier also, mitomycin. This is very important. Whenever you want to cut the conjunctiva or the spiral flap, you always mark it with the caliper. This is very important so that you get uniformity in whatever you are doing. So once these steps are done, so use a buccal wet sponge. This is very important whenever you're creating the flap. This sponge absorbs any blood or any fluid which is there, and you get a nice, very clear scleral flap. So just touch the cutting edge of the 15 number blade at the scleral flap, and it gets cut automatically. And you get a uniform thickness flap. You can see on this that I'm just pulling the flap and touching the blade, and there's a uniform thickness scleral flap which is created. So once this scleral flap is created, then now the thing is, after making the side port, is a single site phacotrab. You enter the entry chamber through this little flap. And now, once you have entered this, you are going to do the phacoemulsification to the same superior site now. So all your steps remain the same. All the precautions of phacoemulsification, which I had discussed in my previous video, is followed. So you are doing the phacoemulsification to the same site. So only thing is earlier it was said that the success rate of a single site is less than the twin site because of the energy which is there, thermal energy which is released at the picosite at the due to the probe that causes failure of the bleb. But when we look at the studies, there's no statistical significant difference between the IOP reduction whether you do a single site or a twin site technique. So this was a single site technique. You can see I'm using only a single releasable suture which is passed through the apex of the scleral flap. So basically, this is the only difference between the single site and the twin site. What is more important is how do you do the surgery? Meticulous planning has to be done. Your tissue handling should be very nice and delicate and gentle. Your cautery should not be a vague, diffuse cautery. You should identify the bleeders and cauterize only those. Coming to the antimetabolite, you should always use sponges. Count the number of sponges that you are going to place subconjunctivally, and when you remove, also count them and remove so that you don't leave anything behind. And always wash thoroughly all your mitomycin. Never leave any traces of mitomycin. When you have naked internal osteum, you can do it with the help of a 11 number blade, a Kelly sponge, or an MVR. So whatever is your preferred technique, you can do that. This is what I was talking about, the anchoring of the conjunctival flap. You take the episcleral or the limbal bite and anchor the conjunctiva. Intermittent locking sutures are put when you do the conjunctival closure. So these are the few steps which I was discussing in these two videos. And as I said, a meticulous surgery, well-planned surgery gives a very good post-operative result. And here I end my presentation by showing these two videos of single site and twin site phacotrap. Thank you, Dr. Bhalla, Dr. Chaudhary, and everybody for giving me a platform to present my talk on this topic. Thank you.
Thank you, Dr. Porwal, for a wonderful presentation. Dr.